Good morning, everyone. My name is Dr. Priyanka Pofle. I'm an assistant professor with the Division of Hematology, Medical Oncology, and Palliative Care. And on behalf of the Department of Medicine, I would like to welcome our guest speaker for today, Dr. Areej El-Jawahri from the Harvard Medical School and Mass General Hospital. Dr. El-Jawahri is the director of the BMT Survivorship Program and Digital Health at the Mass General Hospital. She trained at Harvard Medical School for her MD and did her residency at the Mass General Hospital and fellowship in hematology oncology at Dana-Farber. She then stayed on as faculty and has done a tremendous amount of work in palliative and supportive care interventions for patients with cancers in general and hematologic malignancies in particular. She is an educator, she's a mentor, and she takes great pride in her education role in addition to being a researcher par excellence. She is our 2021 John Peterson Visiting Professor in Palliative Care, and we are delighted to have you here, Dr. El-Jawahri. Please go ahead and present your grand rounds.
Thank you so much, Dr. Pofle, and good morning, everyone. Thank you so much for having me today. It's an honor to be here with you today. My hope for today is to really give you a little bit of a landscape of how to develop a palliative and supportive care research program specifically focused on intervention, development, and testing in patients with blood cancers. And I should say that this is hopefully also a way for us to think about how do we meet the supportive care needs of all of our patients with serious illness, because a lot of the lessons we learned from cancer can really be applied for many, many patients with serious illness regardless of the underlying diagnosis. So I'll try to give you a broad overview of our supportive care intervention research platform, specifically focusing on palliative care studies and early palliative care integration in the blood cancer space, psychosocial interventions, and the concept of trying to translate some of our psychosocial and behavioral intervention to digital health platforms, survivorship interventions, and end-of-life care interventions. I probably won't have a lot of time to spend on end-of-life care interventions, but just to give a little bit of a preview that the hope of supportive oncology in general and supportive care research is really to meet the needs of patients across the continuum of illness from the time of diagnosis until survivorship for those who survive, and certainly to meet and optimize end-of-life care for patients with blood cancers and those with serious illness. I will try to take breaks during the talk. I'd love for this to be engaging for everyone. So I'll try to take breaks during the palliative care section, the psychosocial intervention section, and just open it up to questions. So feel free to please put your questions in the Q&A and discussion as well. And then I'll reflect a little bit on how do we build a really successful supportive care research program. So here is our supportive care research intervention platform in the context of blood cancers. We have several palliative care interventions that have focused primarily on patients undergoing stem cell transplant, those receiving therapy with acute myeloid leukemia, as well as patients receiving CAR T-cell therapy. And actually, what I'm going to do really quickly is I just realized that these are not my most recent slides. So give me 1 second to pull up the most recent slides that we should have up here. Give me 1 second. Okay. That is more like it. So now let's try to resume sharing here. And can you guys see my slides now? Yes. Okay.
Yep,
great.
Yep, we can.
So let's start by looking at our palliative care intervention research platform. When we think about palliative care interventions, we know that studies have demonstrated the benefits of early palliative care in the context of patients with solid tumors. So a lot of earlier studies have shown that early palliative care integrated in the context of the care of patients with solid tumors, predominantly patients with advanced lung cancer, as well as those with other solid tumors, have shown a wide range of benefits in terms of patient-reported quality of life, symptom burden, as well as psychological reduction, psychological distress, and improvement in end-of-life outcomes. However, despite the growing evidence for palliative care benefit in the solid tumor space, as well as the fact that we know that there are immense palliative care needs for patients with blood cancers. Patients with blood cancers rarely utilize palliative care services. And there have been a lot of barriers that have been discussed throughout the literature about why that happens. Why are patients with blood cancers, patients with AML, those undergoing stem cell transplant, are not using palliative care? And a huge aspect of that has been associated with the idea that clinicians in the blood cancer space often misequate palliative care with just end-of-life care. And so the question becomes is, how do we address this knowledge gap? How do we actually address the idea that palliative care may mean more than just optimizing end-of-life care for patients with blood cancers? We also recognize the needs of patients with blood cancers are just different than patients with other solid tumors. So this is also an example of the need to develop a population-specific palliative care intervention for patients with blood cancers. So I want to give you a little bit of preview of our palliative care study in stem cell transplant. This is our first study. This was the SHIELD trial, looking at the idea of integrating palliative care in the context of curative setting. So we focused on patients with blood cancers undergoing hematopoietic stem cell transplantation. We chose this idea to particularly actually overcome this barrier, equating palliative care with just end-of-life care. What is a better way to do that than to actually think about the integration of palliative care in the curative setting? So here what you see is our palliative care intervention platform really focused on intervening during the acute transplant hospital stay, with the idea of really addressing complex symptoms, managing expectations about illness, and enhancing coping strategies for patients with blood cancers. And the hope was that intervening during the acute hospital stay would lead to improvement in patient and caregiver outcomes during the transplant hospital stay, but also with the idea that there may be sustained benefits beyond that. So this was our first trial. It was a randomized single-center trial of 160 patients with blood cancers who were admitted within 72 hours of admission for stem cell transplant, and they were randomized to either receiving inpatient integrated palliative and transplant care versus transplant care alone. Those receiving the intervention saw palliative care clinicians at least twice per week during the stem cell hospitalization process. Of note, these patients did not have any longitudinal follow-up post-transplant hospitalization. So they did not see palliative care beyond the inpatient hospital stay, and that becomes relevant for us to keep in mind. And patients receiving usual care received all the supportive care measures that are part of our transplant care. They were permitted to have a palliative care consultation upon request, but that was not standard of care, and certainly only 2 patients in the study actually received a palliative care consultation. We collected longitudinal data, including data at week 2 during hospitalization. And for those of you who are familiar with the transplant hospital stay, we chose week 2 for a reason. This is the time where patients experience the highest symptom burden and the lowest quality of life that we know from our prior studies, as well as the studies of others. So this is the time of nadir for these patients where they really struggle from a symptomatic perspective. This is looking at our findings across multiple domains. So we're looking at the intervention effects on a wide range of patient-reported outcomes, including quality of life, fatigue, symptom burden, depression, anxiety symptoms. And what you see here is there is an intervention effect that is across all of these outcomes at week 2 during the acute hospitalization stay. What was even more impressive is that we were actually able to see, despite the fact that I told you this intervention was really focused on week 2, right? Focused on the acute hospitalization period, there was no outpatient palliative care follow-up. What we were also able to see is that really we were able to improve quality of life and specifically psychological distress at 3 and 6 months post-transplant. And just to put these numbers into context, this is actually looking at the degree of psychological distress at 6 months post-transplant in the intervention group versus the control group. So this is using standard cutoffs of the instruments that we use, validated instruments that we use to measure depression and PTSD. And you can see a dramatic decline in the clinically significant depression and PTSD symptoms at 6 months. So think about this for a second. Intervening during the transplant hospital stay, during that brief 3 to 4 week hospitalization, led to a sustained benefit up to 6 months post-transplant in terms of reduction in PTSD and depression. And I think that is really remarkable. This is kind of really an example of intervening during an acute traumatic event to really improve psychological health post-transplant. And so building on this work, we are now conducting a multi-site randomized trial of this intervention to just ensure that this is a generalizable care model. It involves integrating this type of care model in the context of stem cell transplant across several transplant centers. I will take that to transition to talk a little bit about how do we take lessons learned from this and incorporate it into a more holistic palliative care intervention model. And this is the case really of palliative care in acute myeloid leukemia. So we know that patients with acute myeloid leukemia confront a life-threatening illness that requires intensive therapy. They also experience frequent hospitalization. And for those of you who know this population, this is also a population that typically, when they receive intensive chemotherapy, are usually admitted to the hospital for about 4 to 6 weeks, similar to what we see in the transplant population. Patients with AML endure substantial physical and psychological symptom burden, but there's also a critical need to optimize end-of-life care for patients with acute myeloid leukemia. And we know that palliative care is ideally suited to address complex physical, psychological, and end-of-life care needs for patients with AML, yet this is a population where we haven't had our interventions really reach. And so the question here is, can we learn from what we did in the transplant study, but really develop a care model that's more longitudinal to address the needs of these patients? Throughout our supportive care work, one of the first steps that we do is really to try to study the population and its needs. And this is just an example of this understanding of this population. So this is giving you a sense of actually patients with AML and how much time they've spent in the hospital and the clinic, both those receiving intensive induction treatment, that's what you see here on the left-hand side. These patients spend approximately 50% of their life from diagnosis until death in the hospital. What you see here is those receiving non-intensive strategy. This is hypomethylating agents, other treatments that are not necessarily causing a 4 to 6 week index hospitalization, are also spending a significant amount of time in the inpatient setting from diagnosis until death. And what you see here is that also we know that patients with AML, regardless of the intensity of treatment to begin with, do have substantial end-of-life care needs and high healthcare utilization at the end of life in the last 30 days of life. So you can see that majority of them are hospitalized in the last 30 days of life, and many of them actually also die in the hospital. So following about our transplant study, one of the other things we did is really kind of say, okay, can we actually learn from how much time these patients spent in the hospital and develop a care model that's focused on integrating palliative care during hospitalization for patients with AML, but also build on this idea that these patients spend so much time in the hospital that we could potentially provide longitudinal inpatient palliative care for these patients. There were two reasons for that. One is we know that the palliative care infrastructure is much, much stronger on the inpatient setting compared to the outpatient setting. So the idea of being able to provide longitudinal palliative care in the inpatient setting allows for potential for scalability and dissemination. And the second reason is we had spent a lot of time in the transplant study really building a relationship between our palliative care clinicians and our leukemia and hematologic malignancy clinicians. And we were really able to prove with that study that really palliative care can do a lot more than just address the end-of-life care needs of patients. And we were able to show that palliative care can really be helpful in the curative setting. Building on that trust, we really proposed the study to really kind of think about a model of care that really spans the entire illness continuum, not just focusing on symptom management and coping during an acute difficult hospitalization. So this was a multi-site study. It included 160 patients with high-risk acute myeloid leukemia who were receiving intensive chemotherapy. They were randomized to receiving inpatient integrated palliative and leukemia care, similar model with palliative care clinicians, saw patients acutely during hospitalization at least twice weekly. They also followed patients longitudinally, seeing them throughout every subsequent hospitalization. There was no outpatient palliative care component, And then patients were randomized to standard leukemia care, where again, palliative care was still available upon request. Again, we focused on longitudinal data collection, including patient-reported outcomes at week 2, as well as some healthcare utilization metrics. And again, you see a very similar pattern here. This is looking at week 2 during the patient's nadir, and here we see improvement across multiple domains of quality of life, depression, and anxiety, as well as PTSD symptoms at week 2, favoring the intervention. And similarly, when we look at the trend over 6 months, we see, here the intervention group is in orange, usual care group is in blue. Here we're looking at quality of life with higher scores indicating better quality of life. And what you see is that the intervention group had better quality of life across the first 6 months compared to the usual care group. We also saw a pattern for anxiety and depression here. The scale is flipped, so higher scores here indicate worse anxiety symptoms and worse depression symptoms. Again, you see that the intervention group had lower anxiety and depression symptoms throughout the first 6 months, as well as lower post-traumatic stress symptoms longitudinally as well. More importantly, in this more comprehensive model, what we are also looking at is end-of-life outcomes. And what we see here is that patients receiving the interventions were more likely to discuss their end-of-life care preferences with their clinicians, and they were also less likely to receive chemotherapy in the last 30 days of life. There were no differences in hospitalization and hospice utilization end of life, which are, I think, really fascinating and interesting and worth also us discussing at some point. Predominantly, I think, driven by some of the limitations to our end-of-life care models for this population. So I want us to kind of think about the lessons learned from palliative care studies here. I think the number one thing is to think about the need to really develop population-specific palliative care interventions. This idea that this is not a one-size-fits-all for everybody, meaning that if we were to take some of the data from early palliative care in lung cancer, let's say, where patients are seen by palliative care clinicians monthly on the outpatient setting, and try to implement that in leukemia, for example, we may not have been actually able to really achieve these similar outcomes for many reasons, one of which is the fact these patients interface with the inpatient setting so much more. We need to understand the palliative care needs of the population to really develop these interventions and have a sense of their trajectory, illness trajectory, both in terms of patient-reported outcomes as well as healthcare utilization. And I'd say being strategic when faced with cultural barriers to integration. I always talk about the fact that when we started our palliative care intervention work in blood cancers, we purposefully chose to intervene in the stem cell transplant population setting. This was not an advanced care planning. This was not a goals of care intervention. It was an intervention that was designed specifically and strategically to overcome the misperception that equates palliative care with just end-of-life care. We were purposeful in selecting that population, and that allowed us to build a relationship with our heme malignancy colleagues. And in the process of doing so, we were able to then think about future integration in the blood cancer space. Stakeholder engagement is critical. I could probably do a whole lecture on how do we work with our nursing colleague, with our social work colleagues, with our spirituality colleagues in thinking about meeting the supportive care needs of this population and really using them as and leveraging their interest in this in building a palliative and supportive care research platform. And I think it's really important to talk about, the questions of relevance for us to the palliative care field moving forward, thinking about mediation and moderation. And specifically, what I mean by mediation is this idea is, what is actually happening here? How is palliative care really improving outcomes in patients with blood cancers? And when it comes to moderation, that is a question that's really critical for us as we think about the future of palliative care integration in the context of serious illness. How do we identify patients who really, really need specialty palliative care? And that's really critical because we do not have enough palliative care clinicians to see every patient with serious illness. And we also don't believe that every patient with serious illness really needs specialty palliative care. So I think the future direction for us is focusing on scalable dissemination and implementation pragmatic trials, focusing really on, now that we've built that trust, optimizing end-of-life care for patients with blood cancers, and developing specialty palliative care integration models for novel populations. I think the challenges of addressing the needs of patients, for example, receiving CAR T-cell therapy is really huge for us. Adoptive cellular therapy in a population that's really facing on the brink of death is one of the biggest challenges from a palliative care perspective. And this idea of how do we compare specialty palliative care versus primary palliative care? What I mean by primary palliative care is this idea that can we train oncology clinicians to meet the needs of patients with cancer? So with that, I'll do a plug for a study that we're hoping to open with you guys as well. This is a large study that's funded by PCORI that's focused on this concept of specialty versus primary palliative care. We're hoping to use 20 institutions. This is a cluster randomized study that is randomizing sites to either delivering specialty palliative care, the model that I just shared with you in the context of leukemia, versus primary palliative care, where we train leukemia clinicians to address the palliative care needs of these patients. And we are looking at a whole host of outcomes, including quality of life, psychological distress, as well as caregiver outcomes and healthcare utilization. These are kind of a broad overview of this care model, the idea that in primary palliative care, we are taking leukemia clinicians, we are training them to address the palliative care needs of their patients, and these leukemia clinicians will care for patients throughout the illness course during every hospitalization, versus our specialty palliative care model, where specialty palliative care is partnering with leukemia clinicians to address the needs of these patients. And again, here, the idea is not, oh my gosh, which one of these models is going to win? But in my mind, the answer to this trial is actually going to be much more nuanced. We're going to be able to answer the question, which patients with acute leukemia really would benefit from specialty palliative care? Can we identify that subgroup at the outset? And if so, can we take whatever factors that we think can identify a higher risk population that would benefit from specialty palliative care? Can we take those and apply them to patients with solid tumors, apply them potentially with patients with serious illness? For example, we could think that patients with low coping strategies, those with poor prognostic awareness and illness understanding, may be a high risk population. We'll be able to identify this. And I suspect many of my leukemia colleagues on this call would agree that there's also a subset of patients that we care for with leukemia who do just fine with primary palliative care, that our leukemia clinicians can address their physical and psychological needs, especially those with high coping skills at baseline. So again, I'll end the palliative care session by saying this is not a one size fits all, that this is a more nuanced discussion regarding identifying the needs of patients with blood cancers, and not all blood cancers are created equally. We have patients such as patients with indolent lymphomas who have low symptom burden and low mortality. And the idea of integrating palliative care early at the time of diagnosis simply doesn't make sense. We also have patients with myeloproliferative neoplasm, where they have a prolonged period with low symptom burden. Maybe we need to identify a triggered model for palliative care. But the idea of developing this as a population-specific intervention in the future is really the goal, is to really meet the patients where they're at. And with that, I do want us to take a little bit of a break here and just answer questions and discuss any comments that people have on this part of the talk. And I'm sorry if I missed any questions in the chat, but please go ahead and ask any questions you have about palliative care, and then we'll transition to talk about psychosocial care.
I'm seeing one question here in the chat from Cassie. As a former inpatient BMT nurse, I very vividly recall distress among staff caring for patients during the transplant hospitalization, likely secondary to the traumatic event of transplant, especially when the course was going poorly. Have you evaluated or considered looking at any outcomes and how the support of palliative care has impacted the staff?
Oh, what a great question. Again, you know, I really can't, there's so much we can talk about when it comes to this piece. I will just share anecdotal evidence, but I do think that one of the things that I wish we had done is actually measure that and measure the impact of these type of intervention on burnout and just general satisfaction on the clinician side. But what I'll say, I will tell you guys, when we started this work in transplant, and I'm a transplant oncologist by training, I vividly recall the first week that we opened the study. And initially, I should say, it's really ironic, we have 2 floors at MGH that serve predominantly patients with solid tumors on one and patients with blood cancers, and really transplant and leukemia specifically on the other. And palliative care clinicians were routinely seen on the solid tumor space, on the solid tumor floor, but they never showed up on that blood cancers. It was like they weren't welcome. They weren't there. They couldn't show up on Lunder 10, our heme malignancy floor. And I remember the first week of the study when I went onto the floor and I literally was joined by our nurses who were crying and hugging me. This is pre-pandemic, so we were appropriately socially distancing, but really, this is pre-pandemic. They came and hugged me and be like, thank you. We see Vicki Jackson, the chief of palliative care here. It's amazing. So these are anecdotal data. I wish I had more concrete data. And I do think hopefully in the SCOPE trial, that specialty versus primary palliative care, because the goal is to really think about how do we scale up these models in the future? How do we actually integrate this in a full way across the nation? In that we are actually going to be collecting data on the clinician level, both nursing staff and physicians, about how they're feeling about both the specialty and primary palliative care models.
Wonderful. We have a question from Eric Marty. Were your specialty palliative care interventions in the studies delivered primarily by dedicated specialty palliative care team members or by coordinated delivery of other supportive hospital resources?
Yeah, it's a great question. The predominant care model here was actually a physician and a nurse practitioner, I should say, seeing these patients longitudinally with inpatient palliative care. So this was not a palliative care intervention that included incorporating the social worker from palliative care. However, I will say that a huge part of what happened here is our palliative care clinicians worked very closely with a social worker on the floor who knows this population, and also worked very, very, very closely with the nurses in terms of optimizing care for these patients. And we tried to measure some of these communication aspects. But I do think that the predominant interventionist, if you will, was an MD or an APP delivering care for these patients.
Toby Campbell is asking, with the stress you've seen on the patients, I imagine the families also face high stress. Are there impacts seen at the caregiver level as well?
Yes. Thank you, Dr. Campbell. I think you're just setting me up for this question. I believe that was intentional. I did not present any of our caregiver data, but we absolutely do. Similar to other interventions in solid tumor space, we've seen 3 really domains on the caregiver aspects that have improved. 1 is caregiver quality of life, 2 is caregiver coping, and 3 is caregiver depression. We also know that patient and caregiver outcomes are highly interrelated as well. So we actually think a lot of the improvement in caregiver outcome, and we have data to support this, are actually mediated by the fact that patients are feeling better. So it's an indirect effect, because actually in a lot of these studies on the inpatient setting, there was a lot less direct interaction between patients and between palliative care clinicians and caregivers. So about 30% of caregivers interacted with palliative care clinicians on the study. But the predominant benefit is actually getting through, making patients feel better, which is actually helping their caregivers.
One last question from Matthew Brunner. Great presentation. How important do you think it is having a hematology-specific palliative clinician, or do you think that a less specialized palliative care provider can engage in these systems? I ask both with regards to patient care, but also team building and inter-team trust.
Absolutely. So I think this is also a great question about this idea of bi-directional learning that I think is really critical in building these population-specific models. Do I think any palliative care, specialty palliative care clinician can really learn to understand the needs of this population and integrate their palliative care domains into the care of these patients? Absolutely. And at the same time, it took time to build relationships with the oncology clinicians on this floor. It took time to really understand the trajectory of these patients. One of the things that I often share with my colleagues is that one of my most proud moments in doing this work was actually walking on the stem cell transplant floor and hearing our specialty palliative care clinician do a sign off to one of the other clinicians about a patient. And she said, this is a 65-year-old gentleman with AML, FLT3 positive. He is day -5 of flu male match unrelated donor stem cell transplant. It sounded like a transplant sign out, but the reality is that meant something to her. She really got a really deep understanding of what it means to be day -6 of flu male match unrelated donor stem cell transplant. And that learning took time and took, she needed to see patients and needed to really have the intellectual curiosity to go up to the transplant clinician and say, hey, what do you expect here? What are you actually seeing in this population that we need to think about? So yes, we can train everyone to get there, but I do think there is some advantage to really building this within the context of understanding this population. And there was a lot of bidirectional learning that took place, both on the palliative care side and the stem cell transplant side. So with that, if it's okay with you guys, I will transition a little bit and try to have us discuss some of our psychosocial interventions. And again, the idea here is actually rather simple. Now, we know that the extent of psychological distress in patients with blood cancers and their caregiver is striking, and why certainly specialty palliative care interventions have demonstrated encouraging efficacy, as I showed you, in reducing psychological distress. There's still a need for more focused psychosocial interventions. And here again, this is the idea of emphasis on scalability and dissemination. Can we meet the needs of our patients in a scalable way that allows us to really reach wide population? This is also an example of work that builds on the strengths of our transdisciplinary team. We work very closely with palliative care clinicians, psychologists, psychiatrists, social work, nursing researchers, all together. And I would say they're all clinician scientists who are actually caring for these patients clinically, but also developing and thinking about sort of how do we study this from a research perspective. So I'm going to try to give you an example of this idea of really how do we scale some of the knowledge gained from palliative care interventions, for example, in the context of acute myeloid leukemia. We learned that palliative care improves quality of life and symptom burden during an intensive hospitalization for patients with AML. We also know that there's lack of access of specialty palliative care clinicians across many institutions, which may limit the scalability of that care model. The fact that it's an inpatient care model helps, but certainly you can imagine that there are certain institutions that even don't have the infrastructure to support that care model. And so we asked the question, can we translate the active components of the palliative care intervention to a digital health intervention to address the needs of patients with AML during this difficult first 4 to 6 week hospitalization? There are a lot of advantages to thinking about a digital health intervention in AML. One, these patients specifically that are receiving intensive chemotherapy are stuck in a hospital for a prolonged 4 to 6 week hospitalization with absolutely no control over what's happening to them. They express a strong desire to do something to help this situation. So giving them a digital health app and saying, hey, this is what you can do, and empowering them to address their issues can be really lucrative. It's also a patient-centered approach to dictating pace and flow of information. For many of you caring for this population, you have seen this. Often these patients are diagnosed urgently. They come from the emergency room to the floor. They're admitted, and essentially within the first 48 hours, we dump a lot of information on them. We tell them they're diagnosed with leukemia, that they have to start urgent chemotherapy, that they need a PICC line, they need an echo, and this is just the beginning of a very long journey. So the idea of trying, and as we know, when patients are facing a threat to life, they close off, right? So cognitively, they probably understood about 10% of what we said to them. So the idea of dictating the pace and flow of information and educating patients about their illness course over time may seem to be a good strategy to use and leverage that time in the hospital. You know, interestingly, part of the reason we thought about a digital therapeutic for this population is they tend to be younger, specifically those receiving intensive chemotherapy. But what's really fascinating to me is actually the people who have been using the app the most are actually 65 to 70 years of age. So I don't think age is predictive of who uses digital health therapeutics. So that's just something to keep in mind. So I'm going to show you a proof of concept study that we just completed. We took 60 patients with a diagnosis of acute leukemia. This is, again, within 72 hours of initiating intensive chemotherapy. And we randomized them to DREAMLAND. It's a mobile app, a digital therapeutic that we hope that they would engage with during the hospitalization. And a lot of the DREAMLAND components are really built from what we thought were the active components of our palliative care intervention work versus usual care where patients receive typical supportive care. And again, the primary outcome, this was a proof of concept study. So first is it feasible? Can you take a really sick population who just got diagnosed with cancer within 72 hours to really use an app, to leverage an app to work on what they need to work on in terms of addressing their coping and psychosocial needs? And then we also looked at quality of life, mood, symptom burden, and the sense of self-efficacy. Are we empowering patients to really address their needs? DREAMLAND components, including a huge component of supportive psychotherapy, which is really built around normalizing and validating that initial shock of diagnosis and loss of independence, which is often what our palliative care clinicians did in their early encounters with this population. There's a lot of illness understanding and education to really help patients prepare, manage expectations, and mobilize their social support network during that acute hospitalization and later on. And I'd say there's a component that's really focused on effective coping, and it's cognitive-based therapy, but it's really cognitive-based therapy light. It's this idea that how do you actually facilitate effective adaptive coping while also facilitating acceptance in the context of living with uncertainty. And there's also a component that's focused on self-care. So I'm going to show you a little screenshots of DREAMLAND. It's set up as sort of a natural journey in the outside world to give people an escape from that prolonged hospitalization. Patients are supposed to engage with certain modules. So module 1 should be completed during week 1 of hospitalization, module 2 during the second week in the hospitalization, and so forth. There is a guide in the app who basically tells patients about DREAMLAND and kind of provide a lot of the educational content, both in audio and in these text bubble format. This is one of the most popular aspects of the app. This is kind of the roadmap that we give people about their acute hospitalization. They go to this roadmap at various points during the app, and they can click on any of these boxes to get more information. But it just gives them a sense of what will happen over the next 4 to 6 weeks. And we have a similar roadmap for what do the next 6 months look like. And so this is what I mean by managing expectation and giving people information that they need at the time that they can process it. Probably the other very, very popular aspect is these patient videos. These are real patients who have gone through this hospitalization, giving their thoughts and advice on how to get through this. Often peer support can go a long way for these patients. And then we do have a lot of gamification strategies to really enhance education. This idea of, for example, we provide the link between thoughts, behaviors, feelings, and behaviors, and then we have patients play a simple game to reinforce the learning and the framework that we're giving them. This is the paper toss game where they need to identify their thoughts, their emotions, their physical sensations, and behavior. Again, this is a game that you are supposed to whack the judgmental thoughts that you have. And this is just another way to reinforce the learning and the concepts that we have. And there's some acceptance and diaphragmatic breathing exercises. These are DREAMLAND feasibility data. So first of all, we had a priori wanted to enroll 60% of patients at least have 60% complete 75% of the intervention modules. As you can see, 62% completed, 75% of the module 3 is sort of the 75% of the intervention module. But more importantly, I would say, out of the people who didn't complete the last 2 modules, the majority of them didn't because they were in the intensive care unit, or they died, or something else happened. And so the reality is they were really, really ill. So we had only 3 patients who just didn't want to complete this, as opposed to really being too ill to complete it. You could see each module took about 20% roughly, 20 minutes to complete, and the mean time spent on DREAMLAND in the hospitalization about 68 minutes. Again, in this very small pilot study, we saw really, really dramatic effects with medium to large effect sizes on quality of life, anxiety, depression, symptom burden, and self-efficacy in this population acutely during the hospital stay. We're now translating some of this to a caregiver app. I'm going to just show you that the caregiver app looks different. I don't have any fun data to show here. But again, the idea is providing people a little bit of a journey, modules that they can complete at their own pace, a guide that they can relate to in the caregiver app. We use Dr. Jacobs, one of our psychologists, who also has videos in the app integrated, so they know this is a real person that's talking to them, and a lot of gamification strategies as well as acceptance and mindfulness-based strategies to help patients cope with their illness. So I don't have data on the caregiver app, but nonetheless, I think this idea of translating some of our active in-person interventions to digital health platform to enhance scalability and dissemination is a really one way to enhance our scope and scalability. This also highlights the importance of transdisciplinary research. I wouldn't be able to do this without my colleagues in nursing and psychology and palliative care to really think through what were the active components in our palliative care intervention and how do we translate those to a digital space. We learned from experiences in other fields on how to think about gamification, for example, and gamification theory as a way to enhance engagement. And really the importance of having a conceptual framework of how do you think your intervention is going to move outcomes. I think one of the biggest lessons I learned as we think about psychosocial interventions and digital translation is really to think about scalability and dissemination early, developing the best intervention in the world that's really labor intensive, that cannot be implemented on a national or large scale is really problematic. And identifying a good industry partner to actually develop these mobile interventions. I certainly can give feedback and guidance on that. I've met with over 10 companies to identify our digital health partner. And I'd say the other thing that's really awesome about this is a way to diversify your research portfolio. It's been really fun for me to really do this, to kind of think about a different care model that I didn't think about before. It really challenged me to think about how do I really get my patients who are really, really ill with leukemia to engage with a digital therapeutic that honors their experience, right? So I do think leveraging technology in terms of future directions for this type of research with emphasis on adherence. A huge, huge problem with digital health interventions is they only work if people can use them. And there are certain ways that we're trying to do that, including think about virtual reality, social networks to enhance engagement in mobile intervention research. We certainly want to expand the psychosocial intervention mobile app platform in novel populations. Again, the idea of population-specific interventions. And then I think, can we kind of think about really developing more innovative hybrid models where we're not relying on technology alone, but the idea of really supplementing in-person or telehealth interventions with a digital therapeutic to really minimize burden on interventionists as well as enhance scalability and dissemination. With that, I'm going to spend probably about 5-6 minutes talking a little bit about survivorship interventions, and then I'm going to open it up for questions for both of these sections. So, you know, I am going to use sexual health as the example of our survivorship intervention work because I do think it's a rarely discussed topic, and I think it symbolizes some of the issues that our survivors face. So sexual dysfunction is very, very common after cancer treatment, specifically in transplant survivors. And honestly, it's rarely discussed among transplant survivors and their clinicians. We know that sexual dysfunction negatively impacts patient-reported quality of life, intimacy, relationship, satisfaction, and mood. We also know that interventions in that space are generally lacking, not I would say just in the transplant population, but across all cancer survivors. And I should say that, you know, one of the important pieces of this is that for patients, this is an example of an issue that allows them to really think about transitioning back to normalcy after cancer treatment. So while it's not important for every patient, there are certainly some patients who really feel like this is an important part of their life. They really lose in the context in facing cancer and any serious illness. So I'm going to show you just one of our pilot studies that led to really our sexual health intervention platform, but this is a very basic pre-post design where we took 50 allogeneic stem cell transplant survivors who actually screened positive for sexual dysfunction causing distress and we intervened upon them. And the intervention here included, one, training transplant clinicians to actually screen for sexual dysfunction. And two, we actually trained transplant clinicians, these are oncologists and oncology MPs, on basic ways to address sexual health after transplant. So the idea here is actually to leverage a primary survivorship care model, right? Training our oncology clinicians to meet the needs of these patients, recognizing that we're not going to become sex therapists, we're not going to become sexual health experts, but we're going to have a little bit of an expertise to address the most common issues facing our patients, and also really normalize talking about these issues. So this was really an oncology intervention, right? This is an oncologist-driven, an oncology APP-driven intervention. We enrolled 94% of patients. This was, again, a feasibility study. So first we wanted to see if we can enroll people. And we were able to really show that all of these patients who enrolled completed their intervention visits. The mean number of visits were actually 2, but we had up to 5 visits with the transplant clinician. And these visits were not super long. They're 30 to 50 minutes. The first one was long, but really everything else was a lot shorter. And I'd say about a third of patients had their partner actually participate in these visits. This is looking at the proportion of subjects not having any sexual activity pre and post intervention. Very dramatic decline in those who are not having any sexual activity. And again, small pilot, but really we're able to show significant impact on various sexual health domains, both in terms of global satisfaction and interest in sex. And that translated to improvement, again, with all the limitations of a pre-post study design in quality of life, depression, and anxiety symptoms. And hopefully in future studies, we'll be able to show that really improvement in sexual function is mediating this impact on quality of life and psychological distress. And with that, I actually want to share with you some of just our qualitative experience talking to patients about sexual health. So this is one of the first patients who said to us, it was a woman who was about 3 years out from her stem cell transplant for leukemia. She said, it's just something you just don't talk about. It never occurred to me to talk to Dr. Jones, her transplant clinician, about this. He saved my life. I thought it would be silly to even mention sex. Jack and I just assumed we were done with sex. I just never imagined getting this part of my life back again. The next quote is actually from a patient who is the oldest patient on study, I believe. She is 79 years old when she participated in the study. And she shared, we are back to our old routine 3 times a week, and it is awesome. I mean, Jim is having back pain again. Is there something you can do about that? Because we would do a lot more if his back wasn't hurting. And I share this because it's also a really great quote about the fact that really sex doesn't know any age limit, that there are a lot of myths about sex, but we had a lot of old patients participate in this trial because this was something that's really important to them. The next quote is actually from a gentleman who I gave one of the intimacy exercises to, which is really the focus is to kind of focus on enhancing physical intimacy and avoid sexual intercourse. That was the idea, at least that was his homework assignment from the study. And this is his message. So we were playing the intimacy game you gave us, but then things got heated and we just had sex. I'm sorry, I hope we didn't ruin the game or the study. It has been so long, but everything worked like it was supposed to. It was amazing. And the last quote I'll share with you is actually an email that I received at 3 o'clock in the morning from a participant who literally wrote, Dr. El-Jawahri, it worked. It totally worked. Best sex of our lives. Thank you so much. Thank you. Thank you. Sent from my iPhone. So again, I share these to just highlight that this is an important domain of survivorship for these patients, but really something that's meaningful for these patients, and because there's a lot of humor here that we can also all laugh about. We are now expanding this research. We're doing a randomized trial based on this study, as well as developing a mobile intervention, a digital therapeutic focused on addressing the sexual health needs of these patients, designed to be used in the privacy of their own home. I will keep the sexual health app PG-13. And with that, I will kind of just talk about the lessons learned from thinking about survivorship needs. This is an example actually of clinical care, insights from clinical care leading to the development of supportive care interventions. The story that I always share is basically I started doing this work because I saw a woman of mine who was 29 years of age. She was 2 years out from her transplant for acute leukemia. She's one of my favorite patients. I saw her in clinic at the 2-year mark. We were celebrating that she was at 2 years. And I was about to leave her room. And she said to me, Dr. El-Jawahri, I'm sorry to stop you, but can I ask you one question? Is it okay for me to kiss my husband now? And I had this mortified look on my face of, oh my gosh, you haven't kissed your husband for the past 2.5 years, because I haven't talked to you about it. She was afraid of getting infections and was trying to kind of keep herself safe. But the reality is this is really a clinical example that led to us really thinking about how do we think about addressing one domain of survivorship here. This is an example of also an intervention where we integrate the intervention into the current care model. So again, we're using and leveraging our current oncology staffing to address these issues. We're focusing on training interventionists. How do we train oncology clinicians to address these issues? And careful assessment of intervention fidelity. How do we actually deliver the intervention as intended? And I'd say the take home for me was to be bold, to not shy away from new adventures like this, right? This is not what I envisioned myself doing, sexual health interventions in transplant, but certainly it was a supportive care need for our patients. And I had a clinical case that really led me to think about this as a potential path. So we are hoping to establish, really definitively demonstrate the efficacy of these sexual health interventions, focus on vulnerable populations when it comes to survivorship. We have a lot of work focused on chronic graft versus host disease, and to expand our mobile app intervention platform for survivors. And again, I think the other piece that we really want to do in the future in the survivorship space is really thinking about how do you address prognostic uncertainty and fear of cancer recurrence. As I mentioned earlier, I probably won't have time to really walk you through our end-of-life care intervention work, but we are doing a lot of advanced care planning video work in patients with blood cancers. And we're actually focusing on hospital at home care as a way to really optimize end-of-life care for patients with blood cancers, and really as a bridge to hospice, but really meeting the supportive care needs in a higher way than just a bridge to hospice program. And with that, I'd say, as we think about building a supportive care research program in any patient with serious illness, it's really important to have a clear vision and a diverse research portfolio. Focusing on transdisciplinary collaboration has been really the highlight of my career so far, and really engaging in patients and families as stakeholders in your research and research partners. Mentorship is critical to the success of any research program. I wouldn't be here if it wasn't for my mentors at Mass General. And really having weekly lab meetings to promote research engagement across your group of transdisciplinary researchers. And more importantly, have fun and cultivate a culture of for faculty to really pursue their passion and what they care about. And with that, I will stop sharing and happy to take other questions, comments about the later part of that talk.
That was a fantastic presentation and very innovative work. Thank you very much for sharing it today with us. We have a question here from Sansia Ferguson, who says, thank you for your presentation. What a wonderful care model in the DREAMLAND project. Can you talk about the development of the app? Did you use patient feedback in design or patient user testing in development?
Yeah, it's a great question. We have now developed 7 mobile apps. The first one we developed was DREAMLAND. So we've learned a lot in the process. The process is incredibly iterative and requires feedback from patients as stakeholders. We've also actually used their caregivers, but predominantly patients, literally with every screenshot that you saw. So there's a lot of iterative feedback on every component of the app and a lot of alpha and beta user testing. So we basically created a group, an advisory group that included clinicians from psychology, from oncology, a leukemia clinician, as well as myself. I'm a transplant clinician, so I wanted to have sort of a really leukemia specific expertise. We had a palliative care physician as well, and a thoracic oncologist who happened to be my mentor, as well as 2 patients and 2 caregivers. And basically all these people met on a weekly basis and reviewed literally every component of the app as it was developed. And we made iterative design changes. Then we did an open pilot with 10 patients once we had a final prototype, revised it based on that feedback. So it took about 9 to 12 months to really develop the app. And I wouldn't do it any differently. I think there are a lot of just user interface questions that come up that are really, really important. There are things that people just get annoyed at if you have to click too many clicks to get to the screen you need to. So just basic feedback can really make a big difference.
Dr. Campbell says, fantastic. Thank you, Dr. El-Jawahri, for what you do. Congratulations on your success. We have an every other week palliative care and oncology research meeting. Sounds like we should go to weekly. I agree. How do you structure the meeting to keep everyone engaged and make it fun?
Yeah, so it's a great question. Our meetings, I would say we have made an effort to really have an agenda for every week. And typically we do a journal club once a month. We really do have people present very much work in progress things and get feedback on them. So the idea is not to have a polished presentation, but hey, this is my specific aims page for my K. Can we discuss it as a group? This is my work in progress on this project. I'm really brainstorming about this new project and this new project idea. And, early on, we kind of really try to go to people and say, we need you to present, we need you to start. Now it's natural, now everybody signs up. But I do think having these meetings are really, really helpful. I think the other thing that now we started to do is our group is starting to think about expanding our health equity research platform. So now we're getting experts in health equity research who are coming and giving talks. People find that really helpful as well. So a combination of expertise and expert talks, I would say, in topics related to research methodology, and really a venue for junior faculty, transdisciplinary junior faculty, as well as mid-level faculty to share their ideas is really a way to make that meaningful for people, and investment from people to really be there all the time.
We only have a couple minutes left, but I had a question. I mean, we often see like these patients who get diagnosed with leukemia come in and kind of are upset about their diagnosis, are angry, and sometimes they decline all interventions. You offer them palliative care, you offer them health psychology or other support, and they refuse it. Is your digital health intervention, are people more receptive to that when they are kind of in that closed space?
Yeah, and I think there is still, unfortunately, across really all of our patients, to be honest with you, with serious illness, there remains a little bit of stigma about the idea of asking for help on the emotional and mental health front. The really nice thing about DREAMLAND is we actually offer this. It is intertwined medical education and psychoeducation and coping. So the way we present DREAMLAND is to say, we know patients with acute leukemia, when they get diagnosed, feel really overwhelmed. They get a lot of information that's really hard to process. We worked with our leukemia clinicians to develop this app that really provides to you up-to-date information about acute leukemia that'll help you understand what's happening during the hospital stay, and will also help you cope with this illness. So it's actually not set up as, oh, you're depressed, let's try to address your depression. And for some reason, that goes a long way. This idea that we are increasing your illness understanding, there's a lot of people who are very, very hungry for information. That really does help. It's normalizing that this is an overwhelming process, and really taking away the stigma away from this type of intervention. Great. I think there's one comment about who are you considering old, and I apologize if I said anything about someone being old, but the reality is, the oldest person who participated in our sexual health study more recently was actually an 84-year-old woman. So really, we have had the extremes of age in our sexual health platform, from people in their 20s to people in their 80s. And our sexual health platform doesn't only focus solely about sex, but this idea of just intimacy and building intimacy between you and your partner as well. So I apologize if I called people old that were not too old in this audience.
we're almost at time. If there are no further questions, thank you very much, Dr. El-Jawahri, and we look forward to the rest of your virtual visit today.
Thank you so much for having me.